Hello everyone, my name is Denise Duclos. I'm the Vice President of the Dystonia Network of Australia. I'd like to, with the other committee members, Lorraine, Kerry and Robin, welcome you to tonight's presentation. And this has been arranged, this is one of three webinars during September for Dystonia Awareness Month. At the end of tonight's presentation, there may be some time for questions. And if you would like to ask Dr. Lagrand a question at the end, please unmute yourself to ask the question and then put yourself back on mute after you've asked it so he can answer. And the presentation and questions are being recorded so that we can put the webinar on DNA's website and YouTube channel. So we ask that the questions be kept to the topic of the presentation and that you don't discuss your personal stories or personal health information. Our presenter tonight is Dr. Lagrand. Welcome, Doctor.
Thank you.
We're very fortunate to have you with us tonight to talk about functional movement disorders. Dr. Lagrand was trained as a neurologist at the University of Groningen in the Netherlands. He participated in the group of Professor Marina de Koning-Thiessen at the Expertise Centrum of Movement Disorders in Groningen. He's currently working on his PhD on associated features in functional movement disorders. He recently started a clinical fellowship at the Movement Disorders Service of neurologist Dr. Alex Len at Princess Alexandra Hospital in Brisbane. So once again, welcome Dr. Lagrand, and we'll hand over the hosting of the meeting for you for your presentation.
Can I share my screen?
Yes, you can share it now.
As I already noticed, some of you, really nice to hear you pronouncing my name. My name is spelled T. Jerk. As you immediately can see, my parents were native speakers, and I'm not either. But yeah, I think it took half an hour here in Brizzy before they started to call me TJ, which is far more easy. So from now on, please call me TJ. I think that's easier. And for this talk that I'm going to give about functional neurological disorders, I try to focus especially on functional movement disorders and especially on functional dystonia, although I think functional disorders in general have a lot of things in common. But I try to tell you a little bit more about this specific subtype as well. And hopefully I can tell you a little bit about the differences between functional and organic disorders, but I think even more important, the things they have in common, because hopefully at the end of the talk, I convince you that, well, what I believe is don't think in black and white, but I think there are actually a lot of gray zones and there's a lot of overlap between these conditions. Well, that sway between functional and organic disorders, that's not something from the last years. That's actually something that's going on for a long time. And as you can see here, this is Charcot. He was a French neurologist. You also saw him on my first slide, on that painting, which is called A Clinical Lesson in Salpêtrière. It's a hospital in Paris. And he was actually the first guy who separated functional neurological conditions, which he called hysteria, from organic neurological conditions. And although he thought that both conditions had a physiological cause, I think he thought dystonia as that specific disease. He classified it with his functional or hysteria disorders, and he called it at that time patients with that phenotype of a twisted muscle. He called them spasms with hysterical symptoms. So he was a little bit more a believer of a functional underlying thing going on in these patients. And then in 1911, Oppenheim came, and maybe you've heard from him from the DIT1 dystonia, the Oppenheim's dystonia. He was actually the first guy who published about 4 Jewish children with generalized dystonia. He was actually the first guy who called it dystonia, or dystonic musculorum deformans, and he was actually convinced that there had to be an organic underlying mechanism for this disorder, and but also he couldn't find a pathological substrate of dystonia. And at a congress around 1930 in Paris, actually that view as dystonia as an organic disease was actually demolished. And around that time, also the view of Sigmund Freud came along, and he came with the term conversion disorder. And he believed that in people who have psychological stressors or psychological issues from their past, that these things can convert into symptoms, organic symptoms, as dystonia, for example. So he actually sent all his patients for psychological therapy with dystonia, because he thought that there had to be a psychological trigger causing these symptoms. And well, not so well, as you can imagine, a lot of those patients with dystonia who were sent to the psychologist, actually, they didn't benefit from that therapy. And around the 1975, David Marsden, he was the guy who was actually, he found out 2 things. First of all, he found out that people with basal ganglia disorders, so problems in those nuclei in the brain, they actually can develop certain dystonia subtypes, for example, cervical dystonia. And he also found out, he showed that with electrophysiology, that there is this thing going wrong with agonist and antagonist muscles. So actually and we're talking 1975 now, he said, well, all those dystonia patients that we called hysterical or conversion disorders, they're all organic, no doubt about it. There's no, actually for functional dystonia, there wasn't a place anymore. And hopefully, now it's 2021, I think most neurologists, and I know Alex and I do here in Brisbane, think, well, dystonia, there actually, you have 2 subtypes. You have functional dystonia and you have organic dystonia, but it's not so black and white. There is a lot of overlap between these disorders, and I hope I can show you in the rest of my presentation. Well, talking a little bit more about functional disorders, I think it's also important to be consistent with your language. And as you could hear in my talk about the history of dystonia, a lot of different terminology came along. I mentioned hysteria, I mentioned psychogenic disorders, but I think we really have to think that when we tell one of our patients that they have a certain disorder, we actually, with our diagnosis, we're delivering a message to them. And you might not be bad with that, but if you say to one of your patients, well, you have a non-organic disorder, the patient can go out of your clinic room and says, well, you can tell me what it's not, but can you tell me what I have? Or for example, if you say you are suffering from pseudo seizures, so the patient can think, well, you actually say that I'm faking it. Or if you say, well, what you have is actually medically unexplained symptoms, that patient walks out and thinks, well, that guy, he really didn't know what is going on with me. And I think, therefore, that functional, actually, the word says what a disease is. There is a problem, not in the structural pathways of the brain and nervous system, but in the function. And that's thing people can understand. And then they can say, well, yeah, oh, so that's why my scans are normal. Yeah, because there's no structural damage to the system. Oh, but still I having the symptoms. Yeah, because you have problems with brain functioning. And it's not me making this up. Actually, there's a beautiful study done in the early 2000s. It's done in Scotland, and they went to a neurology outpatient clinic, and they asked patients this specific question, like, if you would have leg weakness on one side of your body, and your doctor would say, well, this is caused by, and you can see here on the left side of the screen, symptoms all in the mind, psychosomatic weakness, chronic fatigue. What do you think that the doctor is telling you? And then they give them several options. For example, well, I'm making it all up, or I'm mad, or I'm actually suffering from a medical condition. And what they next did is they calculated the number needed to offend. And I think it's fascinating, because in a lot of studies, we use the number needed to treat to see how many patients do we have to treat with a specific type of therapy or drug to see benefit from it. And with the number needed to offend is actually how many people do I have to deliver a certain message before they get pissed off with me. And actually, for those at the top, that number is very, very high, as you can expect. And for functional weakness, yeah, people get it. It's not only, I think, a proper way of explaining a diagnosis, but also a diagnosis which is acceptable for most of your patients. Well, then a few things I would like to cover when I have a talk about functional neurological disorders. I think, first of all, functional neurological disorders, they're not rare. They're everywhere. And this is also coming from a study of Scotland. They do a lot of research there about functional neurological disorders. And they actually went to several neurology outpatient clinics, and they asked the neurologists, well, what kind of diagnosis have you made today? And as you can see, functional neurological disorders after headache were the second most common diagnosis in a neurology outpatient clinic. And you can divide FND between different subtypes, and I think the most common type of subtype is dissociative attacks. So attacks with loss of consciousness, with based on a functional origin, but also functional movement disorders, very common, and also functional dystonia. And because I don't have very good data about how often do you see functional dystonia, but what I can say is this is a study that I did 2 years ago in Groningen. And well, first I have to explain, I worked in Groningen in a very super specialized neurology clinic where we only saw people with hyperkinetic movement disorders. So a lot of dystonia patients, a lot of tremor patients, a lot of myoclonus patients, no Parkinson's patients, for example. But in our cohort, as you can see here at the top, we screened 900 people, and more than a third turned out to have a functional movement disorder. And of that third, that group of people with functional movement disorder, not less than 1 in 4 showed functional dystonia as their motor phenotype. So I actually think, again, there is some selection bias in this cohort, but I think functional dystonia is a pretty common feature. Other myth about functional neurological disorders, that functional disorders can only be neurological. No, they cannot. And I listed here a couple of diagnoses that you can see in different clinics, in different specialties. And look, I'm not saying that these diagnoses are all functional disorders, but I think a lot of them can very well be explained using a functional framework in your explanation to your patients. I think actually these disorders have a lot of things in common. And so thinking functional neurological disorders is only something for the neurologist. No, I think not. I think there's a lot of overlap with other specialties as well. Other myth about functional neurological disorders, they are bizarre. Well, maybe I'm a young neurologist, but I work for a couple of years now in a movement disorder clinic, and I see a lot of bizarre things going on. This, for example, is a patient, and she told me she couldn't walk straight forward to me. And I said, well, but how did you get here? Huh? You came to my clinic room, so how do you move? Because she wasn't using a wheelchair or for example. And she said, well, I can't walk forward, but I can walk sideways. And when I raise my knees, I can walk forward. And that sounds bizarre, but this is actually a patient with Parkinson, which has freezing of gait, which is very common in people with Parkinson. But as you can see at the last frame, I asked her, walk forward now, normally, and she couldn't. So it's pretty bizarre, but this is not a functional disorder. And this guy, for example, if you see how he walks, that looks strange, doesn't it? I think that's really weird. But this is not a functional disorder. This is actually a guy with DIT1 dystonia. And this is what they call a clasp knife gait, with that hanging of the trunk to one side. And as you can see, he also does it when he stands on one certain spot. But yeah, this is not a functional disorder. So also organic movement disorder can sometimes look a little bit bizarre. Well, what do we know about functional disorders? And if they're not bizarre and if they're not rare, what are they then? And I always try to explain it this way. I think, look at the brain and your nervous system as a sort of a computer. And there are two different ways your computer can shut down. Definitely, if you crash the cable work and have to say, this is not my own computer, this is not after one day working here in PA hospital. Sometimes I have this feeling maybe, but when the cable work is damaged, yeah, your computer won't work. For example, in people with stroke, in people with MS. But if you have a computer and you try to start 20 different of programs, or for example, when I try to be the host in this meeting, my computer also shut it down and it's not functioning that way. But if you look at the outside, that computer looks normal. Yeah, it does, but it's not functioning. And I think that's the key point in functional neurological disorder. So how do we make a diagnosis of a functional neurological disorder? Well, I think, and that's according to the DSM-5 criteria for functional neurological disorders, you have to look in your clinic room for two hallmark features, which are inconsistency and incongruity with other neurological diseases. And inconsistency can be internal inconsistency. For example, somebody with a tremor disappears when he is distracted. And incongruity means incongruent with other neurological diseases. And then you have also to know how other neurological diseases look like. So you have to be a bit experienced. For example, if you remember that guy with that clasp knife gait, if you never have seen that, I think that sometimes it can be pretty difficult to recognize that as a DIT1 dystonia, for example. And how do we make the diagnosis? We make the diagnosis based on so-called positive symptoms. So in this guy, for example, we look for, this guy is suffering from a bilateral upper limb tremor. And here we try to distract him with a calculation. And you see that the tremor is still the same. But when we let him copy a certain movement with one hand, you can see that the tremor on the left side first stops and then entrains to that same frequency that we ask him to tap. And this is what we call ballistic movements. So you make sudden fast movement with one hand. And as you can see, if he moves, tremor stops, comes back again. If he moves, tremor stops again, tremor come back. So that shows the variability and inconsistency of that specific tremor. And that's something you don't see with other types of tremor. This is something you don't see in your patient with Parkinson's disease, for example, or essential tremor, that entrainment or distractibility. So that's a positive sign. And also important, when you see this in your clinic room, it's not that you then say, now I got you, that tremor disappeared, so you have a functional disorder. It's not, it's not tricking your patient, but what you can do, of course, is when you see this in your clinic room, you can also tell your patient, look what happens to your tremor, and look that the cable work can still function normally, but in some way it doesn't. But there is this reversibility in these disorders. So that's why you have to look for these positive symptoms, but also use them in your explanation to your patients. Then coming back to functional dystonia, because this talk is of course for the dystonia network. Positive symptoms in dystonia are difficult, and that's why I actually have to admit that functional dystonia is maybe one of the hardest movement disorders to phenotype between organic or functional, because it sometimes can really look as an organic disorder. And I think I listed here a couple of positive symptoms that you can see. I think when somebody has an acute onset of their dystonic limb, for example, I think that's a good, that is a clue for a functional disorder. Instead of most people with dystonia, they have a more slowly progressive disease course. Other thing is a fixed dystonia. It's quite typical in patients with functional dystonia. For example, if you look at cervical dystonia, which is the most common type of adult onset dystonia, you see often very patterned stereotyped movement of the neck, but you can also see a tremulous movement sometimes, and you can sometimes see that when people have a sensory trick, when they hold their chin, for example, that the head can go back to a more normal position. And in functional dystonia, it's quite often a body part is totally fixed. There's no movement at all, no tremor, for example. As I showed you before, distractibility, common in functional movement disorders, but not so common in functional dystonia. As you can imagine, if you have a fixed limb, it's sometimes very hard to distract that. We don't have an entrainment test for that, for example. And in the literature, there's a lot of debate going on about suggestibility. So that if you say, if you inject people with botulinum toxin, for example, or with a placebo, that functional dystonia can disappear quite easily. But on the other hand, you can also say that a sensory trick is maybe a sort of suggestibility in it. Because when you actually think about it, if I just put my finger on my forehead, my dystonic posturing disappears. So it also sounds a little bit suggestible, but I still think that sensory trick is clearly something we see in organic dystonia. But there is some overlap here as well, I think. Just to show you a couple of pictures, because I already told you, I think there's a lot of overlap, but what are the things that we typically see in patients with functional dystonia? Well, this first picture, for example, is a patient with a functional facial spasm, and typically in functional dystonia of the lower face, you see that also accessory neck muscles are involved, or the platysma is involved, and commonly it's only on one side of the face, and you have some jaw deviation to one side, and that is not so typical for an organic dystonia. Next picture is a guy with functional blepharospasm, not a very common subtype of functional dystonia, by the way. But what you can see, if you compare that with people with organic blepharospasm, normally it starts with some increased eye blinking, and at a later stage, it can be a more prolonged contraction or prolonged spasm. But in functional blepharospasm, we often see that prolonged spasm already in the beginning, so pretty acute. So that's something that differs between, but sometimes very difficult to see. And here you see, I think what's actually, the most people I see with functional dystonia have functional dystonia of a limb, and what's pretty typical is the flexion position of the wrist and the fingers, and sometimes also the elbow is involved, and this plantar flexion with inversion of a foot, which is then often a very fixed limb dystonia. That are the typical things that you see. And as you might know, these, especially in adult patients, I think these focal dystonias are pretty atypical. I think in adults, you far more commonly are the cervical dystonia, the blepharospasms, the writer's cramp. That are the most common adult onset focal dystonias. So if you see a focal dystonia in a limb at somebody on an adult age, I think, you have to think about functional dystonia as well. And then, people often ask me, all right, you told me these things now about how you diagnose functional disorders and what are positive symptoms, and maybe I disproved some myths that some people have about functional neurological disorders. But why? Why do some people develop these conditions and some people not? And I think, just to cover one big misunderstanding is that still 2021 neurology, a lot of neurologists think that there has to be an underlying psychological stressor or underlying psychological issue with a functional neurological disorder. And data showed that's not the truth. Certainly, underlying psychological drivers as anxiety, depressions are important in people with functional neurological disorders, but you don't have to have them to developing a functional neurological disorder. So some people are really focused in, when they see a patient with functional dystonia, how was your childhood? Did you experience any trauma? And again, I'm not suggesting that you shouldn't, but go a little bit easy on those things. Because as you can see, I here listed some risk factors for people with functional disorders and organic disorders, and specifically dystonia. And female gender is more common in functional disorders, but also cervical dystonia, for example, is something that happens more in. There's also a female predominance in that specific phenotype. Positive family history, yeah, very common in organic dystonia. But hey, guess what? Also very common in people with functional disorders. Not quite rarely, I have a patient with a functional dystonia here in my clinic who says, well, actually, my father suffers from non-epileptic seizures. And I think, hey, it's something super common also for functional disorders. Underlying anxiety, depression, as I mentioned, super common in functional disorders, but hey, also very common in people with organic dystonia, pain, fatigue, same thing. So a lot of overlap. And I think, first of all, we have to stop being so keen on that underlying psychological issue in people with functional disorders. I think, yeah, true, can be, but see it more as risk factors. I think if you compare it, for example, somebody who suffers from stroke, I ask them for, well, do you smoke? Do you have diabetes? Do you have high cholesterol? What about physical exercise, family history? But if somebody tells me that, well, he or she doesn't smoke, all right, I'm not saying then, oh, but I think you're lying, or I think you suppress the memory of smoking. No, if they say that there's not, then it's not an issue for them. And same thing with underlying anxiety, depression in functional neurological disorders. Of course, I ask, do you have do you experience problems with low mood, for example? But if somebody says to me, well, no, I don't, well, it's off my list. So you have to see those psychological drivers. I think you have to see them more as risk factors than that they are the sole cause of functional disorders. Well, what do you think then, and how does our brain actually work? And I think there are some fascinating studies done about this subject. And I think, well, easy way to explain it is think as your brain as a sort of prediction machine. And I think we actually, all our movements are based on certain beliefs and expectations on, well, how our body works, how our brain works, and how the world around us works. And based on our prediction, we actually constantly adjusting our movement. And you have actually these two things. I think you have your sensory data coming in, also called bottom up or feedback, but you also have a lot of predictions about sensory data. And I try to make it more easier to put this in a picture. If you look at the guy who is just gonna to hit that ball here, yeah, definitely sensory data is coming in that's guiding his movement towards the ball. Visual data, for example. But what about the other people in this picture? What about the people on this side of the net? They are not waiting to getting new sensory data in. No, they are already predicting where that ball is going to come. And based on that prediction, they're moving. They actually already are moving to the place where they think that ball is going to get. And maybe on even a higher level of processing and on prediction making, the guy on the same side of the net, here in the left top corner, is also already moving based on his prediction about, well, where does my fellow hit the ball? Where will they hit the ball? And he is already moving towards that position. So these predictions can be very strong. And I think actually they determine how functional neurological symptoms can look like. And to show you a good example, I think, of how strong predictions can be. I love this video. It's an old video, by the way, but this video shows you an example of a hollow mask of Charlie Chaplin. And as it comes around you in just a moment, you will definitely see this is a hollow mask. Here you can see that. But then something weird happens. If you look now, that face is popping out. That's strange, because we just saw that's a hollow mask. And here it's hollow again. But that way of thinking is actually based on your prediction of how a face should look like. So those predictions are so strong that I can show you this video again, and now you know that's a hollow mask. But when it turns around again you see that face popping out. So those predictions are actually a lot stronger than the new sensory data that is coming into your system. And I think that's how our brain works. We cannot constantly process our movements. No, our movements are based on very strong predictions that our brain has made in the past. And if you think about that, and you look at this lady is suffering from functional hand dystonia, and she is if you think about prediction, she is now about to get botulinum toxin, and she has a very strong belief that this will kind of cure his dystonia. And as you might know, botulinum toxin, it takes a couple of days before it starts working. But what you see here is after injection, her functional dystonia completely disappears. And you can say, yeah, that's the placebo effect of your treatment. And yeah, of course, that's true. But if you look at it from a more biological way, you can also say, well, actually, this lady had a very strong prediction that this treatment would cure her dystonia. And it did. It definitely did. So I'm not suggesting that we have to give all our patients with functional dystonia botulinum toxin. I actually think that if you do that, these patients, they tend to relapse quite quickly, because, well, sometimes they are actually more cured by magic than by a treatment where they had self-control over. And as you can imagine, it can be very scary if you had a dystonia for a couple of months and somebody is giving you an injection and it suddenly disappears. So anxiety is, I think, a very strong driver as well. But you can see how very strong predictions can result in sudden movement disorders as dystonia in these patients. That's how I think you should look at this video. And well, just to show you one last study about that, maybe because I think it's not only about predictions, there are a lot of other mechanisms going wrong in people with functional neurological disorders or functional dystonia. For example, a lack of self-control, for example, or attenuation to their own body. But I think what I said in the beginning, there's also an overlap between organic and functional disorders. And I think, we learned a lot in the recent past about CRPS, chronic regional pain syndrome, and again, I'm not saying CRPS is the same as functional dystonia, but a lot of overlap between these two conditions. For example, patients have shown to have these abnormal illness beliefs, anxiety problems, fear of movement, very common in CRPS, loss of agency, actually same things that are sometimes underlying a functional neurological disorder. And to show you one last study about this and how it also can go wrong with sensory data coming in, I think super interesting study. What they actually did, super simple. They took healthy individuals, actually the researchers, and they casted their dominant arm for 2 weeks. And every day they went into this functional MRI scan to look for a resting state MRI. And what they showed in these patients is that within 48 hours, so within 2 days, they could already show functional disconnecting of cortical and cerebellar regions, controlling their extremities. So, and after 2 days already, a sort of prediction can result also in, well, functional motor disconnectivity in the brain. And also important, after 2 weeks, when they removed their cast, these disconnections also disappeared again. So showing the reversibility, but especially showing the importance of getting in these patients very quickly, because I think that's one of the last lessons I wanted to give you is the worst prognostic factor in functional neurological disorders or functional dystonia is chronicity. So if people are suffering from a functional movement disorder for many years, it's very hard to shift those brains. And I believe is that we have to get in early to get them the right therapy for these disorders. Then we have a chance shifting these brains. Coming to one of my last slides about therapy, what can we do then about functional neurological disorders and functional dystonia in particular? Well, normal things. Be normal to these patients. What do you do with a person with Parkinson's disease, for example? You first say, well, you have Parkinson's disease. So to my patient with functional dystonia, I say, well, you have functional dystonia. And then I explain them why I came to my diagnosis. So in a Parkinson's patient, for example, you say, well, you have this stiffness in your right leg and you have a reduced arm swing while walking, and I see this resting tremor. But hey, that's the same thing I do with my functional patients. I also explain them, well, I showed you some distractibility, there's some positive signs, and that's how I made my diagnosis, because these things are very specific for functional neurological disorders. And then I explain them something about the mechanisms going on. And I think that hardware, software metaphor that I used in the beginning of the presentation is very helpful, and patients get that as well. I don't focus too much on the why, so I don't go very hard with that things about predictions, for example. But hey, I also know why. If I have a patient with Parkinson's disease and he asks me why did I got Parkinson's disease, well, I would be a very good neurologist if I could tell them exactly why they got that disease. No, I can't. And I also can't do that in functional neurological disorders often. I make a treatment plan based on those underlying drivers. And I give my patients some homework about functional neurological disorders. And nothing fancy, but we have this lovely website here in Australia. It's called fndaustralia.com.au with some very good videos of what are functional disorders, how we treat them. Then you have this English website. It's from that Scottish group I mentioned, neurosymptoms.org. Very good website. I think I actually show all my patients. I mentioned this website to them, and they have, for every functional neurological subtype, they have these fact sheets. For example, this is the one for functional dystonia. And well, I know I can totally understand that you can't translate Dutch so good, but this is our Dutch website that we made. And for example, we put some videos for exercises for patients with people with functional dystonia, which they can do to hopefully reduce symptoms. So yeah, these are the things I use in my clinic room. And then about therapy, I think you really have to do that with a tailored based approach. So for some people, some people with functional dystonia, physiotherapy will work. Some people, psychological therapy will work. But when people have very strong underlying drivers, for example, chronic pain, you can get them to the best physiotherapist in the world, but they wouldn't resolve their problem because they are in a constant pain, and that brain is in constant red alert state. So then when people tell me, well, I have chronic pain and that's actually bothering so much that I can't do anything because of that, then you first have to do something about that pain before you can try to shift their functional movement disorder. So tailor-based approach, and there's no one size fits all. It's just hear what the patients say, what are their specific underlying drivers and triggers, and work on that. Of course, I end with, well, this is very recently published in Movement Disorder Clinical Practice. I think 3 weeks ago, they published actually 3 cases about how difficult treatment can be in people with functional dystonia. And I'm totally not suggesting that you should do this in all your patients with functional dystonia. But what they offer them is this 6-step intervention approach. So they first put all those patients on functional, so first standard treatment, so physiotherapy, psychology, psychiatry, a pain clinic, if that was, and if that didn't help, they sent these patients for this 6-step intervention program, which included electrical stimulation, botulinum toxin, but also at the end, surgical release of the Achilles tendon, so surgery actually, and they showed, well, in the patient they did that she could walk again and return to work. Again, not saying that you should do this in all your patients, but you can have a very highly selected patient group in which you try things like this. Well, end of my talk. Last thing I would love to say is please get in touch. As you can hear, I can talk on the water about F&D. So if you have any questions, please grill me, or if you are keen to look at more information, I would definitely recommend our website, fndaustralia.com.au. And if you are a little bit hesitant to ask me a question now in public, you can also always drop me an email, and I will respond to that as well. So thank you for having me. Thank you for, well, sharing one of my passions in neurology, and thank you for the invitation.
See if anybody has any questions for you. I think we've got time for a couple of questions. Is there anybody who would like to unmute themselves are you able to stop sharing your screen now? Definitely. Yeah. And then I can see the other. Okay.
Yeah, perfect.
Right. Is there anybody who has a question for Dr. Lagrand? You could unmute yourself and ask it now. I've got a question that I wanted to ask. When you say that there's overlap between functional movement disorder and organic, does that mean that it's possible that a person could have elements of both in what they have? And how do you then treat that, and who sort of coordinates the care in a sort of situation like that?
Yeah, definitely. Very good question. I think, well, when we look at our patient with functional neurological disorders here in the movement disorder clinic, we see actually a lot of people who first suffered from, organic movement disorder and then developed a functional overlay sometimes. And what I do is I actually tell them both. So if I have, well, positive symptoms for a functional disorder, I say, well, clearly you have, for example, a cervical dystonia here, but the fact that I can distract the tremor away from you, that's actually a sign of a functional neurological disorder. And I would discuss that with them. And I would say, well, are there maybe underlying drivers, anxiety that are, for example, that are causing these issues? But yeah, super common in people with functional disorders that they also have another neurological condition. Yeah.
And how do you sort of coordinate the care if you're looking at a holistic sort of model of care? How do you coordinate care when it might involve other specialists, a primary care physician, physio, that sort of thing?
Yeah, again, depending on their specific underlying drivers. So if they tell me, well, if they suffer from a functional neurological disorder, but pain is a big issue for them, which is pretty common also actually in people with organic dystonia, and that is stopping them from well, normal movements, then I think you have to address that first. You have first to address that pain first. And if they say, well, I'm actually suffering from a lot of anxiety problems, also super common for both, I would say, well, then I hook you up with a good psychologist who gonna work with you on that. So I would, well, look at what are somebody's underlying drivers are, what are somebody's specific triggers. What we have on the FND website, for example, is we have this, well, FND handbook that we can give to patients, which they can bring to their psychologist or physiotherapist, and that they can use in their treatment. And that is actually pretty personalized. That's about their specific triggers and underlying drivers, and use that in your therapy. So yeah, most of my patients, I send them as well as physiotherapy and psychological therapy, but first getting those underlying drivers right. And if there are other issues, deal with them first. Yeah.
Okay, I understand that. Okay, anybody else?
It's Lorraine here. I wanted to ask Tjerk, you spoke about how important it is how patients are told about a functional diagnosis. I get the feeling this wasn't done very well in the past.
No, that's well, one of our, well, Alex and my main goals is to change that. And I think actually what we see is that the greatest part comes from neurologists. They don't want to be bothered with people with functional disorders. They don't have the time for that. But I actually think if you look at the data and if you see how common functional neurological disorders are, it's actually a little bit cocky if you say, well, I don't got to deal with these patients, if that's 1/3 of your population, isn't it? So yeah, things went wrong in the past, I think. And I think it's, well, I also see the problem of time, because as you might know, people with functional neurological disorders are pretty time consuming sometimes. But yeah, really worth working for. And I actually believe if you do it right in the beginning, that saves you so much time at the end, because those patients get sent away by the GPs, by the neurologists, by the rheumatologists, for example. And actually, if you do that explanation part right in the beginning, that's I think one of the most important steps, and should be your first step of treatment in these patients.
To prevent them becoming chronic, and then
exactly, and that's why we should be, well, we should be better in that, I think.
Does anybody else have any questions before we finish up?
Lorraine, hello, it's Alex Lynn. Sorry, I snuck in very, very late.
Oh, that's okay.
Just in the car picking my daughter up from her dance lessons. But on a positive note with that, what I wanted to add, what we certainly see is a lot of interest amongst health professionals in that nowadays. So I see lots of bad, but I can truly see the positive changes. People want to do better. They know they haven't done a good job until now, but they don't know what to do, and they need that guidance, they need that teaching, and we see a lot of interest, particularly amongst neurologists as well, young neurologists, but certainly all other specialties as well. Things are changing, they truly are.
Okay, well, we might wrap it up now. I'll put myself back on video. Tiak, I'd like to thank you. Sorry?
TJ.
TJ, sorry. Yes, we're big on nicknames here in Australia. So
I learned that.
Thank you very much for your presentation. It was really interesting, and I wish you all the best with the rest of your time in Australia working with Dr. Len and your travels around Australia. I hope you see some absolutely amazing parts of Australia before you go home. And yeah, thank you very much.
Thank you very much for having me and letting me share this with you.